It's really nice to be up here, and I remember the conference, which was about 18 months ago, and there was some enthusiasm, but it was much more tentative, and I sense a real engagement now. So I'm delighted to be here, and I'm really glad to talk with you about some of the work that has happened in Australia. When I started working in research, one of my bosses said to me, nothing you will do will be new. And I think in a way that was trying to take me down a little bit and set my expectations slightly lower. But what I wanted to say is that there are a group of people in Australia who've been pioneering this work unsung for many years, and I wanted to really pay credit to them, because when we started to think that this was something important on the horizon, we went and talked to those people, and they've actually been very generous in advising us as we've gone along to learn the things that they did that were good and the things they did which they regretted, and to take us forward. So much of this is based on conversations with Kathy Eager and David Currow and others from Australia. So I'm going to talk to you about what Peacock is. Somebody said to me, "Is it a bird?" And I said, no. It's actually PCOC, the Palliative Care Outcomes Collaborative, which was first started in Australia. And when we formed Oak, we took some of their ideas, and so we had the Outcomes Assessment and Complexity Collaborative. But it was just a way to try and get it in people's minds. And of course now everybody talks about Oak and they know what they're talking about. But in Australia, you would be talking about Peacock. So I'm going to tell you a little bit about what it is. I'm going to tell you a bit about what they do and how does it compare with what we're doing in Oak. I'm going to tell you a little bit about how they support palliative care services, and you can think about whether those ideas would work for you. I give you some example of findings, and then where they're going to nationally with quality indicators, with some of the national workshops that they hold, and what that might mean for us for future directions. And I hope when we come to the panel, we can have a bit of a discussion about where this might take us. I'm always of the mind that, we should go and really interrogate people and learn what they've learned, and then try and apply for our context and our setting to make it work the best possible for us. So this is the Peacock logo. It's a national collaborative across Australian palliative care services, and there is a website, and I've written the website at the bottom because if you want to go and look at it, it is amazing the amount of materials that are there about individual care that's being provided in those services around the country. So don't feel daunted, but just go and have a little look and see what they've got there. They have set it up to be a framework for demonstrating and improving the quality of palliative care. It aims to embed national clinical assessments, and it is built around assessments, but then repeated assessments to take us from simple assessment into outcomes data collection. Because outcomes are about change, so you've got to measure them several times. And they really regard it as their palliative care vital signs. And so that's what they talk about when they have conversations with policymakers and government. These are our palliative care vital signs, in the same way as you would go into a hospital and see temperature and pulse and blood pressure for everybody in the service. These are the headlines for palliative patients. And it's all about trying to drive quality and outcomes, and the feedback loop that we've been talking about in the workshop earlier is critically important for them. Both improving individual care, but also improving care for the whole cohort of patients within a service. It's actually set up as a partnership between 4 universities, Wollongong, Queensland, Flinders and Western Australia. I really want to go and visit them because I fancy going to some of these places, but haven't quite got there yet. But that was how it was set up in order to have the scientific credibility to take it to a national platform. It's actually led by Cathy at University of Wollongong, and Cathy's been an advisor to us on the OAK project. So there are several key features about what they do that we might want to think about. First of all, it's voluntary. Okay, and this is a really interesting one, Barry. I know you'll have maybe different perspectives on this, but when we were working on the clinical data set, we were hoping to move towards a mandated point of view, but there are pros and cons about whether something's voluntary or mandated. Voluntary, you get people on board at the time they're ready, really. Mandated, you bring along all the people who are dragging their heels as well, and probably there are issues around the quality of data, and there are issues around when is the right time for organisations to engage. And Cathy, in our conversations, has often said to me, it should stay voluntary, because she's a passionate believer that actually that's the best way to drive best quality care and the demonstration of outcomes. And surprisingly, they have had almost all services sign up. I think it's about 88% of services in the country that are signed up. Some of them that aren't are actually, they do have some sort of quite a lot of diversity in some of the more rural areas with small services. But most of them have signed up to this voluntarily over a period of time. Now, somebody also said we're a marathon, not a sprint. And I really wanted to say to you that I've been amazed at how fast some of the outcomes work has progressed in the UK. It's actually going much faster than I had anticipated. They started the development work for some of this actually in 1996, but they then really started to move it forward more concretely in 1998. And they only introduced a standard set of clinical tools, clinical measures, in 2005. So already you can see how many years it takes to begin to get this conversation going. They reviewed the measures clinically in 2013 and actually decided not to make major changes. I think Cathy was in two minds about whether there should be changes, and I'll tell you what they were tempted by, but we'll come to that in a minute. And they've then progressively developed key quality indicators and outcome benchmarks only from 2009. And so you can see how this is a process that takes time, and the benchmarks were very much developed in consultation with the sector, which I think is the best way to go. It means that you get it right, rather than being pushed into benchmarks that maybe commissioners start to expect before the sector is quite ready. And the benchmarks are reviewed and modified based on the trends, which I'll talk to you in a moment about. And this is just the number of patients, episodes, phases, and services submitting data. Okay, so it just depends which one you're looking at. You can see there's a dotted line, which is services who are taking part in this, but there's a gap to the red hard line, because actually some services still submit data that is not of good enough quality for them to be included in the national returns. So it is a bit of a learning process, and it's a question of taking everybody along that journey. So there is point of care data collection at the time of seeing the patient. There is routine returns of that data on an aggregated level to Peacock, to the collaborative. There is national benchmarking, and there's structured feedback. So they actually have an organisation which is funded by the government, which has a data return from each of the participating services, and they deliver a report to each of the services which tells them how they're doing. And they also generate national reports which are then put onto the national website. The detailed reporting is not made public. It's the headline data that's made public. We can talk about that if you're interested. The interesting thing that they introduced, which we have tried also to promote, is the unit of counting. So, as I have said, an outcome is a change. And so if you're going to have a change, you have to define the time points over which you're going to measure that change. And the choices with fixed time points, every 3 days, every 7 days, or with a variable a variable time interval, and we chose to go with phase of illness, which is what they had done in Australia. The reason that we did that is that it's more difficult to get people to measure that, because an unstable phase might last 3 days, it might last 7 days. But it is more sensible to try and follow what is happening clinically. And we know that actually you need a lot of intensive input into an unstable phase, whereas if somebody's stable, you may not need much at all. So it makes sense to try and drive the outcomes with phase and phase change rather than fixed time intervals. But it's a harder learning curve at the beginning. So they built it on phase of illness, and we have followed that. And we have followed it because the science was there. They haven't published as much on phase of illness as we would have liked to have seen. But we have seen the detailed reports that they have done internally. They have been generous to share those with us, and I think we were very convinced that phase of illness was one of the key drivers, and that's why we've had conversations with Public Health England, with NHS England, and really been keen that that was adopted within Oak as well. So what do they collect, and how does it compare with Oak? So they have 5 assessment measures or outcome measures. Functional status and dependency. Can I just make a statement that those are 2 different things? Functional status is really the headlines around mobility. Dependency is what you need to deliver to provide the care. And they are 2 quite distinct things, and they report differently. So sometimes people, generally they're less functionally able and they're more dependent, but sometimes they don't quite go together. So they were measuring phase of illness, something called RUG-ADL, which is a measure of dependency, and then AKPS, which is a measure of function. Okay, so in Oak, you'll see functional status and dependency, phase, Bartel, and AKPS. And Bartel is the English equivalent of the RUG-ADL. They are virtually interchangeable. The only reason we didn't use RUG-ADL is because nobody who doesn't live in Australia has ever heard of it. So you can see the top 3 are identical. And that was because we felt there was the science, and we felt it would be directly transferable. Now, the other bit is pain, other symptoms, other problems. And what they use in Australia is something called the Palliative Care Problem Severity Score, and SAS, which is a symptom assessment score. The first one, PCPSS, is a staff score, and the second one is a patient score. And when we had conversations with Kathy in the early days, she said, look, these are not ideal. They're what we had at the time. And actually, the scientific and psychometric evidence for PCPSS is actually very limited. It's a 4-level scale which doesn't behave very well psychometrically. 5 levels actually behave much better. And also it was 4 approximate domains. Those of you who used it for the funding pilots will know it was a bit headliney, and it was so headliney that the detail was lost. And Kathy and the team in Peacock have used POS and IPOS at different stages for more detailed pilot work and other studies that they've done. And Kathy sort of said to me, look, if I was doing it now, I think I wouldn't use this, I would use IPOS. So we had a bit of a serious think about that, because, which one do you go with? And there are alternatives to IPOS, so there's ESAS, which some of you may have come across, there's MSAS, there's a few others. And we did a bit of comparative work to really understand where was the evidence and what might be best. But in the end, we went for IPOS just because it is brief and it covers the whole range. So it's not simply symptoms, it's actually all of the other concerns and problems that people themselves report. So you can see that there's a sort of transferability between what went on in Australia and what we chose to do. We added views on care because we worked with St Christopher's at taking what was most useful from SCIP. The original SCIP took POS questions and quality of life questions and additional questions, and we sort of disaggregated it again to get IPOS and views on care. But the reason I've put it in green is because views on care is not quite an outcome measure. It's asking patients to report something about the difference a service has made, as well as something about their well-being. And it's a little bit of a hybrid, but it's not technically quite an outcome measure. So I've sort of put it in there because it's useful and because it's practical, and that's where it fits, but it doesn't quite fit in the same schema. The carer measures, as Sarah has alluded to, were problematic, and they're problematic a bit in the funding work, a bit in the palliative data set, and I think we really still haven't understood how best to track family problems and concerns. And one of the biggest challenges is that there's not one family member for each person. Sometimes there's nobody, and sometimes there's several people. And that makes it very difficult to aggregate into a meaningful cohort item. So it's a challenge that we haven't yet sussed. We've talked quite a lot with Gun Grandy over in the University of Manchester, who's led a huge amount of work on carer assessment. And I think maybe in the future we'll be able to crack that one, but at the moment it's a difficult one. So if any of you are thinking about using Zaret or the carer measures, it may be something to sort of think about how you use it, and can you aggregate it with the rest of the data items. So in Australia, again, going back to what they do, they report the different, all of these different measures back to services and give them a standardised data set every 6 months with that information. I wanted to talk a little bit about how Peacock works with services, because some of these ideas might be good ones, some of them we may think are less useful. So they provide these 6 monthly detailed reports, which is confidential to that service and it's not shared with other people. And it's unique to that service, and they also, if required, provide a regional report. So some of the different areas also look to a regional report, and if the services all agree, they will produce that as well. And I've given you some of this information, and you can just see a little headline of it, but if you want to look at those, the information they provide, it's all detailed on the website. They also provide what's called quality improvement facilitators, and that's actually people who are usually clinically trained, who can work with services to help point them in the right direction of how to implement the tools, how to work with services. And we took this idea and implemented it in Oak. But because Oak was a funded project, we didn't have much resources, and there was only really 4 of us in the team, we were a bit limited in how much of that quality improvement role we could provide outside of the core Oak teams, which were only 9 teams. So you might have felt a little bit shortchanged that we couldn't provide as much as you might have liked. But they do, in Australia, they work quite closely with sites to help them in some of the challenges around making the measures work in practice, training staff, and then getting the reporting out of systems. They also support and promote champions for the Peacock work within services. And we have found in Oak that actually it's quite helpful to have a champion at every level. So to have a champion on the coalface in the teams, but also a champion at sort of the middle level as well as the senior leadership level. They hold national benchmarking workshops. They have at least 4 a year, and they get peer services together. They only share data about services with the agreement of all the services. But the last one they had, I think only 2 services out of all of them declined to have their data shared. So I think most people are quite happy, once they're confident in the process, to actually have their data shared. And there are professional rules of engagement about how you handle the fact that some people are doing better in some areas or less good in some areas, and respect of how people are trying to make an improvement. And the purpose really is to learn from each other. So they tend to put together services where, similar size services where one might be doing pain management really well and another one doing it less well, or another one where they're doing psychological care really well and another that they're struggling to get the targets. And so in that way, services can have conversations. Well, what are you doing in your service that's so good, that's getting your results right up, and what are we doing that we need to think about changing? But in a very open and a a very relaxed way, really. How can we learn from each other? It also links into Care Search. I don't know if any of you are familiar with Care Search. It's a resource website, and some of the resources there are really helpful at supporting clinical practice. So they've developed it in conjunction so that there is a resource to support practice. And then I suppose finally, I didn't really realise how much this happened, but Kathy would say this is perhaps one of the most important parts of what they do in Peacock, that it actually raises the profile of palliative care and gives public recognition to what services are doing. So when a service hits benchmarks, they have media releases, they make a big fuss and they say this is really important. This service is doing really well, it's excellent, service of excellence, and they often get items in the press and things like that, which has really helped raise the game for palliative care and take it out of a sort of hidden corner that everybody's working there, but people don't hear about it in the health services, and really answer the question that Heather raised earlier, what is palliative care doing for the health economy? And then it gets it right out there. There's also, they allow or they support really different people to work on their own service data for conferences, and then they do quite a lot of work on academic publications. And if you want to look this up, there's quite a lot of publications around how they've used the Peacock data over the last few years. Okay, so I'm just going to headline quickly through some of the kind of findings that they're getting to. So this was a 6-month period in 2015, and you can see the kind of numbers of patients we're talking about. 8,000 inpatient, 2,500 in hospital consult services, and 10,000 in the community with episodes and phases. They are very similar in profile to the people that we see in terms of age distribution, average age, etc. So, and their episode lengths are similar as well. So the average episode length in an inpatient context about 12 days. I think it's about 13 and a half days for us in the UK, and so on. So it's just, I put this up just to give you an idea that it is a similar kind of population and a similar kind of set of services. The only thing I would say is that we have a higher proportion of non-cancer. I think that our services are changing more quickly in that respect. And similar to some of the data we've seen earlier, distribution of phase according to setting. So you can see that, for example, in the community there are more stable. We had a conversation in our group earlier about whether that's really changing from Barry's data, and actually there are many more unstable people in the community in the last few years. So I think things are changing, but this gives you an idea. Similarly, you can see that the community patients have a better functional status as compared to inpatients or consult services. And then these are the headline kind of problems that they see. So it's a similar kind of patterns of data that we've seen from a UK context. So the exciting bit is, or the threatening bit, depending on how you look at things, is what about moving towards national quality indicators which are based around outcomes? So what have they done? They've moved towards benchmarking, but they've moved slowly towards benchmarking over a period of 4 or 5 years. And they've done it talking to the sectors because the sector needs to be confident that any benchmarking is fair and meaningful. And I think it's quite exciting. We're in conversations at the moment about whether we might do some international comparisons. And I think that's in its very early stages, but it will be very exciting if we can begin to do that. They have very strict criteria about selecting a benchmark. So it's got to be something that's clinically important. It's got to be something where there is evidence of variation between services. So if, for example, we found that every service was doing excellent pain management, there wouldn't be much point in selecting it as a benchmark because there isn't much room to drive any change. So it's got to show variation. It also has to be a domain that's amenable to intervention. So it's not much good picking something that's really hard to change. And then the other thing that is striking about what they do in terms of benchmarking in Australia is that they don't pick an average. They pick best practice. So they're not trying to say everybody should do as well as the average. They're trying to say if 20% of services can get pain management to this level, well, what's happening in the other 80% of services? Can we think about that? Is there anything we can do about it? So it's quite ambitious in its scope and its direction. But we are about excellence, and I think we should really look for those kind of benchmarks. And then they also make sure that the benchmark is the same regardless of sector, which is sensible. And they do some case mix adjustment. Now, case mix adjustment sounds complicated, but it's very similar to age and gender standardisation if you're familiar with standardised mortality ratios. So, you know, the fact that death rate in this hospital or that hospital might be very different because of a different age distribution in their populations. So rather than saying this hospice and that hospice are directly comparable, you're saying we think the complexity of people in that service is much greater than in that service, and so we will adjust the outcomes to allow for that. And it then means you've got a level playing field and you're comparing apples and apples as opposed to apples and bananas. And so that's what they do as standard for all of their benchmarked data. So they don't make any comparisons between services without doing case mix adjustment. What do they try and drive towards in terms of their standards? So these are some of the national indicators that they have developed. Firstly, that 90% of people have their episode commence on the day of, or the day following, the date they're ready for care. So they've developed this concept of the date ready for care, which is not quite the date of referral, because sometimes you get referred somebody who's in hospital, but they're going to be discharged 2 days' time. In which case, 2 days' time would be the date ready for care. So it does mean a little bit of extra data capture, but it makes sense. So 90% of people should be seen within 24 hours. They also said 90% of people in the unstable phase for less than 3 days. It's quite ambitious, because if you look at the data we've got, there's quite a distribution of length of unstable phase. But if you think about it, people are dying and they've got limited time. And they don't want to be in a phase where their problems are not actually actively being resolved. They want to get out of that into a stage where their symptoms and problems are stable or controlled. So in a way, that's what we're about, trying to reduce the time that people are in the unstable phase. Initially, they had it longer than 3 days, and they've reduced it. I think it was 5 days, and then they reduced it to 3 days. What do they say about symptoms? Well, they have 2 approaches to symptoms. One is that people with moderate or severe problems should actually then have absent or mild, whatever the problem is, at the end of that phase. So if you've got severe pain, you should end up with absent or mild pain. If you've got severe breathlessness, you should end up with absent or mild breathlessness. And at least 60%. And that allows for the people who are harder to help and maybe deteriorating. And then they also look at the same thing that Heather mentioned, that if people haven't got a problem, we should be trying to anticipate problems and prevent them happening. So 90% of the people who come in with an absent or mild pain should stay that way and not develop a pain. It's a different way of thinking, but they are finding that these two kind of approaches together are very helpful. And they have now, since 2009, set these benchmarks and look to see what percentage of services can achieve them. And you can see it starts at 2013 on the left over to 2015. So over this 2-year period, you can see the proportion of services achieving benchmark are going up. The benchmark is the red line, and you can see the different settings are having different issues, okay? So trying to push up the timeliness of care. Of course, it's harder to get the timely care going if they're in the community, yeah? So you would expect that that would be a harder one to achieve. But what they're showing is that year on year, a greater proportion of services are achieving it. Similarly, with time spent in the unstable phase, again, they're aspiring to this benchmark. They're not actually there, but they're getting there. So again, the different settings, you can see that gradually over 2 years, with the same benchmarks, everybody's moving in the right direction. Similarly with the start, and this is the one about staying stable if you are stable, and similarly if you start moderate or severe and becoming absent mild over time. They've had trouble with pain particularly. Kathy was talking to me about what affects pain control, and actually they found that some of the smaller services do much better because they have stable staff, and some of the bigger units where there's quite a turnover of trainees and training staff, they find it a lot harder to get near the targets. So they also had this research question, was can outcomes be nationally improved over time? And that was what they looked at across 45 services over a 3-year period, and they basically showed yes, you can systematically improve these outcomes over time. It's quite exciting data. They've published on it if you're interested. And I think this was the data set they used, over 60,000 patients. So it's a very convincing bit of evidence. Not only did they get statistically significant improvement in all domains, they got a steady reduction in the amount of variation. So they're having quite large variations across services to start with, and those gradually narrowed. Okay, so the national workshops, I just wanted to say a brief word about those. They have got a range of different services, 116 services participating. 16 didn't get an outcomes report because the data quality was too poor. It's very similar to the sort of proportion we were finding with the clinical data set. They just weren't ready to deliver the data in a format. And so what you can see when they have these national data sets is that each service will have a letter. So you might be service B, and obviously you're doing really well in relation to hitting the target for time from ready to care to the episode start. But you might be a service down here which is actually not doing so well. And you can then see, with the case mix adjustment, where your service is in relation to other services. Similarly for time in unstable phase, so quite a bit of variation. I don't know what D's doing, but I'm sure there was reasons. There's always reasons, and this is about uncovering the reasons and then addressing them. And I think there was a lot of transition in the team in that particular service. But it's about understanding where a service is. And the identity of the service is, as I say, only revealed if people are happy about revealing it. The adjustment, the case mix adjustment, is specific for each of the items in both the patient scored and the staff scored measures. And the way to interpret a Casemix adjusted score is that actually if you're 0, you're about average. If you're greater than 0, then generally your patient's change is better than similar patients in the national database. And if it's less than 0, then generally your patients are doing worse than those in the national database. And so what you can see there is that in the middle, if you're service L, you're doing about similarly average. If you're up the top there, you're doing better. If you're down here, you need to be worrying. And so it really begins to contextualise what's happening in services. And similarly for pain. So in summary, I guess thinking about where they've got to in Australia, I would say that it seems to me they have taken time, and I think probably we're going much faster than them already, but there's still a long way to go. And I think Antonia's idea of the little sapling or the little plant is a really good one, because there's a long way to go to grow up into the big oak tree. And you can begin to see from this some of the possible directions that we may be able to go. In Australia, they do have several outcome centres. They have about 15 or 20. And there are 3 that are particularly relevant. One is obviously Peacock, which I've talked to you about. There's also something called AROC, which is a rehabilitation outcomes collaborative. And there's also one for persistent pain. The sort of pain clinics and the pain services all contribute to EPOC. Obviously good at thinking up names. But they do have slightly different models in how they're resourced. Peacock is currently voluntary, and there is a lot of government interest in mandating participation. But I think the Peacock team are very concerned about that. They're worried about what that will do. The AROC is self-funded on a membership model. So all of the services subscribe in to the collaborative in order to get the data and the engagement out. And I think it's very much up for discussion about what might work. Before I finish, I just wanted to mention a couple of things. Sarah, in your talk, you were talking about whether the whole combined set had been validated. And I just wanted to say that in our Sea Change project, we've just finished data collection of 2,500 spells of care with all of the data that was collected nationally and more, in order to do exactly that, to validate the whole combined set. In particular, understanding where there are unmet needs, because we don't want to embed services where needs are being unmet as the standard. So that data has just coming in, and a couple of the Sea Change team are here, and if you've got questions you can catch one of us later. But it will be really interesting to analyse that sort of quite rigorously and understand whether the whole thing together does work. And we're just about to start a next phase of our work, which is then testing that over time as we follow patients for up to 18 months through their illness journey, because it must work for individual patients in order to work at all. So you will begin to hear some of that data coming through at presentations and publications, but it may take a little time. We've also just released, it's just about to be published next week, a version of IPOS which is for use in patients with dementia and impaired capacity. And that will go up on our POS website within a couple of weeks or so, and it's being published in Palliative Medicine. And I know a lot of people have asked me, is there an IPOS version for use in dementia or severely impaired capacity? Well, it's just arriving, so there you go. And lastly, I did want to say that we're looking to bid for funding to try and set up some sort of voluntary collaborative, very much like the Peacock one, but learning the lessons. So if any of you have any thoughts about what might work better, or you want to hear more, then please give me a shout later. Thank you.